Hi, you're very welcome to this evening's Be Ready to Play webinar. We're very lucky to be joined this evening by the very experienced John Norwig. So John is the head athletic trainer for the Pittsburgh Steelers, and our webinar is advice from the NFL on Be Ready to Play. So without further ado, John, I'll pass it over to you, and thanks very much for coming on this evening.
I'll share my screen here.
Yeah, thank you, John.
Are we good?
Yes, that's good, John.
Okay. First of all, I think the audience might consist of physiotherapists, athletic therapists, maybe a physician, and some coaches. But what I want to talk to you guys about and share with you is, first of all, I'm not a professor. I'm not a researcher. I'm very clinical in nature. I'm an athletic trainer. I've been with the Pittsburgh Steelers for this will be my 31st season coming up. So for the past 30 seasons, I've been with an athletic trainer in the National Football League. Prior to that, I had the opportunity to work at 2 different universities and also worked at a primary school. And I wanted to share with everybody that what we're going to try to do is talk about COVID 2020 and how do we exit this pandemic and how do we practice and protect our athletes at the same time. I want to thank Des Ryan, Cathal Craig, Seamus Burns for working with me and allowing me this opportunity. I want to also share with those of you that are on this webinar how I came to know Ireland a little bit better. My owner, the team owner of the Pittsburgh Steelers, is Dan Rooney. Dan Rooney has his humble beginnings. His family is from Ireland. And in the 1990s, interestingly enough, he came to our training room and said, my niece from Ireland is going to shadow you this training camp. Her name is Joanne Regan, and I think Joanne is teaching somewhere in sports science in Ireland. So this was in the 1990s, and she may have been the first female participant in an athletic training room, and that was a big deal. She did a great job. Our training room was connected right to the locker room. So it was a unusual situation, and to be the first female in that situation in the NFL, she did a great job handling that. My next interaction with Ireland came through the Irish Rugby Football Union, and I befriended a gentleman by the name of Liam Hennessy, and Liam came over and spent some time with us. Not only in the athletic training room, but also with our strength and conditioning folks. Liam then gave me the opportunity to visit the Irish Rugby Football Union in Dublin, and I got to meet Barry O'Driscoll, who was the team physician at that time. I'm not sure who the physio was, but I had a wonderful experience. I spent 5 days. I spoke to some folks that were involved with the Irish Rugby Football Union about concussions. A few years later, Barry's son, Gary O'Driscoll, who I know worked for the Irish Rugby Football Union and now is associated with Arsenal in the Premier League, and Connor McCarthy came over and spent 2 weeks in our training camp. One last interaction with Ireland was in 1997. We spent 10 days in Ireland, 7 to 10 days. We played the Chicago Bears in Croke Park in 1997, and that was a wonderful experience. Our hotel was right next to Lansdowne Roads Stadium, and it was an awesome experience. A physician that was our contact at that time was a gentleman by the name of Ray Moran, and I think he's still held in high esteem. He was an orthopedist with a special interest in the knee, and he was our liaison, I think, with Black Rock Clinic was the name of it, in Dublin. One last person that we've had an association with is we had a young man that is, I think, active in the Gaelic Athletic Association. His name is Kevin Dunn, and he spent a training camp working with our strength and conditioning folks. Finally, I'll mention Dan Rooney again. Dan Rooney was not only, he's deceased now, he was not only the owner of this team, it's still in his family. He was the U.S. ambassador to Ireland, so I had the opportunity to visit him and his house in Phoenix Park in Dublin. But enough about that. What we're here to talk about is how we transition. It's my understanding that you folks that are involved in the Gaelic Athletic Association have been quarantined, much like the U.S. Well, when I had the opportunity to know that I was going to speak to you, I had to do some homework, because quite honestly, I never heard of Camogie. And I took the opportunity to look on the internet to see if there were any videos of this game, and the ladies that play this game, the closest similarity in the U.S. would be something like women's lacrosse. But I can tell you, the videos I watched of Camogie, it's a much more violent sport than what the Americans play with women's lacrosse. You have to be one tough gal in order to participate in this sport. I read about some lady all-stars that play Gaelic football and watched videos and realized that these ladies are true athletes, that they're strong, they're quick, they have both anaerobic capabilities and aerobic capabilities. This Gaelic football is much more of a aerobic game than the U.S. football. I did find that here in Pittsburgh, we actually have a ladies Gaelic football club. And if you can look at their shirts, you can see that UPMC actually sponsors them. UPMC in Pittsburgh is the biggest healthcare provider in our community. I also looked at the men. I've held a hurling stick, I've seen a hurling ball, but have never really witnessed a game in person. Again, I looked on the internet and saw a tremendous amount of athleticism on the field. To be able to throw a ball with a defender on you and whack it through the uprights at midfield is quite an accomplishment. And the speed and agility and the ability to balance a ball on the stick and run and kick it or punch it, whatever, it's quite a sport. And the video that I watched, I think it was held at Croke Park, and the crowd was phenomenal. It looked like the games that we have in our own National Football League. Men's Gaelic football is similar to our game in one manner. You guys hit each other. I know you're only supposed to hit with your shoulders, but I think the game is much rougher than that. And you folks do it without pads. So, and it's continual motion. It's a great game. And certainly what we're going to talk about, soft tissue injuries, hamstring injuries, occur in your Gaelic games. I did want to share my game with you. This happens to be the last time the Pittsburgh Steelers were in the Super Bowl, and it's about a 2-minute and 30-second clip of our game that we played in Tampa, Florida a few years ago. So bear with me, there's a commercial at the beginning, but it's about 2 minutes and 30 seconds long.
That's not playing there, John. You might have to move on to the next slide, John. Sorry about that.
Well, it's my understanding that you didn't get to see that. Is that correct? It didn't come through?
No, it didn't come through, John. Sorry.
I'm sorry it didn't come through, but the point I wanted to make is you might ask why I would show Gaelic Athletic Association sport and then show a clip of a Pittsburgh Steelers game. The point is that the hamstring injury is the same, whether it's in the National Football League or in the Gaelic Athletic Association. Hamstrings don't favor a gender. It affects men, it affects women, and we treat them the same. Now, during our COVID 2020 season, there were many alterations. No fans, restricted travel, social distancing, face mask, and daily testing. The difference that happened during this COVID time is the National Football League recognized in order for us to protect ourselves against soft tissue injury, there would have to be a gradual return to sport. So if you look on the slide, it talks about NFL annual schedule. Our off season actually begins at the very end of our season. We tell our players to take time off. And sometimes that's in January, sometimes that's in February, but we really won't start up with our off-season program till the middle of April. And this will go through the middle of June. During this time in April, we start with our endurance type activities. We start with strength and conditioning. When we move into May and June, we start to more skill activities, and they're allowed to interact with coaches, and we actually have practices. The preseason, at the end of June, the players get about a month off, and then in late July, we start our preseason. During this preseason, we have a short ramp-up period without pads, and after about 5 days of no pads, we start with pads and we start with practices. We have 3 preseason games, 3 preseason friendlies, whatever you want to call them. We have 3 preseason contests in front of fans. This year, no fans, pumped in noise, all that. Our regular season consists of 17 games. Games are played every week. So you play on Sunday, and generally you don't play till the next Sunday. There are some changes. There is 1 game on Thursday. There's 1 game on Monday night. I'm sure that is to keep the fan base up and the interest, and to I think it's all about money. I think they need a certain number of games, and we can get more people to watch. They get that's better for the television. Our postseason, if you qualify for postseason, can add up to 5 additional games, and it ends the first week in February with the Super Bowl. Now, over the past 8 years, this is the list of soft tissue injuries that we've seen. And if you can note, the most significant injury that we have is the hamstring. That's the largest time loss injury that we have. These are, when we say 256 injuries over the last 8 years, these are not things that where an athlete may have a very, very mild hamstring strain or quad strain or groin strain, what have you, and plays with it. These are actual time loss injuries. So this is a little graph of what we're looking at. And obviously, the largest time loss injuries that we see are with the hamstring and the groin. In fact, these 2 injuries are second only to the ACL. And these time loss injuries are a huge problem for the NFL, because not only do you lose the athlete, but you're losing the salary that you pay for them. And both the groin and the hamstring can be long recovery, and especially with the hamstring, there's a high risk for re-injury. So this is another graph of the injury trends that we've seen in 2013, 14, and 15. You can see that it was relatively low, and that's because our record keeping at that time only existed during our preseason and our regular season. Since 2015, it's been year long. We see an aberration here in 2020. It's not, I don't think it's because we got smarter. I think it's because of the COVID environment. There were no preseason games. We didn't practice in May and June because everybody was quarantined, but we started our season really that last week in July. Hamstring injuries usually occur in our skill athletes, running backs, tight ends, wide receivers, and they generally occur, if you note, during our training camp. They don't occur so much during the season, but they occur when we're practicing and have our preseason games. One thing of note, when we're in our training camp, we have 90 athletes. When we start our regular season, we have a total of 60. There are athletes that do not make the team and are cut before our regular season. If we look at ACL tears, this is all the ACL tears in the NFL. And if you'll note, there are, out of 32 teams, there's 59, 56, 54. So even though this is the largest or the longest injury to recover from, the frequency of the injury is not nearly as significant as the soft tissue injuries that we see. So the way we, in our electronic medical records, this is league-wide, we have the same record-keeping system. What we define time loss as a minor injury is something where you lose 7 days or less. A significant injury is something where you lose between 8 and 21 days, and a major injury is where you lose over 3 weeks, 22 days plus of injury. Now, the NFL data that I have about lower extremity injuries extends from 2015 to 2018. And the estimated time loss during that period per team or per league year was 56,700 player days lost. 58% of our injuries occurred in games, and they were all lower extremity. The hamstring strain was the most common lower extremity injury, followed by lateral ankles, groin strains, high ankle sprains, and MCL sprains of the knee. The risk factors for hamstring strains. This is what's in the literature. Whenever you see this dark slide, it means these are my physician slides. But age, inadequate warm-up, those are all important, but the final one that's most important is the history of prior injury. It's 2 to 6 times greater. You have a 2 to 6 times greater risk of injuring your hamstring if you've had one injury prior to before. These other things are important, but if you've had a hamstring, we really have to pay attention to that athlete because their risk of injury is, like I said, much higher. One thing that is not a risk factor is flexibility. Poor flexibility does not mean you're going to injure your hamstring. If you're overweight, a big man doesn't have a greater risk, or someone that is very lean. If you're running fast, you don't have to be running fast to injure your hamstring. Many of our bigger linemen aren't running very fast when they injure their hamstring. So these are other things that we think are, and the literature tells us, are not put you at risk for hamstring strain. When someone does hurt their hamstring, many times you're going to know it. You see a soccer athlete here grab his hamstring, or a sprinter at the end of the run pop their hamstring and grab for it. Well, there's 3 phases that we have to pay attention to as we evaluate this person, treat this person, and rehabilitate this person. The first is the inflammatory response. You know, for the first 3 to 7 days, it's red, it's hot, they're swollen, there's pain. The second phase is repair or regeneration, and that takes 2 to 8 weeks. And that's when we're getting new collagen fibers laid down, and it's our responsibility to know that it is in a disorganized fashion and to rehab them in a certain way where we can do this, where we help that tissue get in a more organized fashion. And the final one is the remodeling and maturation, where we get strength increases. We try to organize that collagen in a way that will allow us a risk that is less for an injury. Well, what do we do with these athletes when we know they've injured their hamstring? Well, initially we treat them with first aid, and it's common practice for us to use simply shutting the athlete down, getting them quiet, using cryotherapy as much as we can. That's maybe some compression. These are specific tests that we use in our training room. Let me get this up. This is called a drag test. We'll have them do it on the uninvolved side first and see if they have hamstring, whether it's the upper hamstring or lower hamstring. So we do the uninvolved side first, and then we do the involved side. If an athlete tells me that they can feel something when they do this, I know that they're not ready to run. If they say, I feel that, you may think it's very mild and they can return, but I think the risk for further injury is very, very high if they tell you they feel something. The next one is the plank test, and we have them do it 10 times on each side. This is the uninvolved side. Again, we're looking for weakness. Some people won't be able to plank after a hamstring strain. One of our tests to allow them to participate is the ability to do 10 planks, and they shouldn't be touching their butt on the table as they do these planks. Again, it is done in a bilateral fashion so that we can compare the involved to the uninvolved side. The final part of the evaluation, obviously palpation is part of it. We look for a defect or a deformity. And then the manual muscle strength test. We do it at 90 degrees, at about 45 degrees, and at 15 degrees. And what we're looking for is there a weakness. We compare it again bilaterally. Usually the weakness that we find is at the last 15 degrees. That's when somebody's going to tell you that it's painful. In the more acute phase, maybe they are tender at 90, maybe they are tender at 45, but generally it's at that 15-degree mark. Almost everyone in the NFL is going to get an imaging study when they have a hamstring strain. But what's interesting is it's not just the imaging that's important. Obviously, we can see a cyst here. We see more on this person on the left. And on this person on the right, we see just the fluid, that's the biceps femoris. Well, the person on the left missed 3 days, the person on the right missed 56 days. So even though they have findings on their MRI, it's not always telling of how much time they're going to miss. And this is just a different view of that muscle. We can see this is the gentleman that's a wide receiver that missed 3 days, even though he had signal on his hamstring. He only missed 3 days. This guy with signal in his hamstring as well, missed 56. So we have to not only use imaging, but we have to use our evaluation skills. So what do we do with this person that has a new hamstring? Our goals during this first phase are to protect the healing tissue, minimize tissue atrophy and strength loss, prevent motion loss, and avoid excessive active or passive tissue lengthening. We don't stretch people. We don't put the muscle on stretch when someone has a hamstring strain, and we think that actually makes the injury last longer. So rehab, somebody 1 to 2 days of rest. We get them on a stationary bike as soon as they can handle it. do isometric, multiple angle isometrics, progressive hip strengthening. By that I mean straight leg lifts, pain-free knee flexion. We again continue with cryotherapy, maybe some modalities like electrostimulation for pain control. But that's basically our phase one. During phase one, over the last, I would say, 15 years, we've used ortho-biologics. Now, what do I mean by ortho-biologics? I mean, as you can see in this, where number one is, we draw a person's blood. And this was illegal in the Olympic Committee for a period of time. The World Doping Agency didn't allow this. You draw blood, you spin it in this centrifuge, and then you get platelet-rich plasma. And we inject that based on the MRI into the tissue. It can be either with an MRI or you can use ultrasound guidance. And what does that do? Well, you're injecting a high concentrate of platelets, whether it's called platelet-rich plasma or autologous conditioned plasma. And these platelets contain large amounts of growth factors. So they can initiate and accelerate tissue growth. Minimally invasive procedure. In our hamstring protocol, it can be done up to 3 injections. Obviously, a physiotherapist, at least in the United States, or an athletic therapist or athletic trainer in the United States wouldn't do this. We work in conjunction with our team physician to make this happen. This came about when the Steelers were in the Super Bowl 40, which was in about 2006. We had one of our speed guys, a wide receiver, get a lateral blow to his knee, a valgus blow to his knee, and he had a grade 2 medial collateral ligament sprain. And at that time, our team physician, Jim Bradley, decided to try this. We had 2 weeks, and the young man, his name was Hines Ward, it's well documented here in the United States, played in the Super Bowl, but we really believed at that time that this orthobiologic, this ACP that we use, had a role in helping him participate. He wasn't himself, but he did participate, he contributed, and because we won, this made some national media attention. So after 10 years, we decided it's time to look at return to play in the NFL, and our doctor and his fellows and we looked at ACP and compared that with hamstring injuries to those people that did not receive ACP. So from 2009 to 2018, it was the Pittsburgh Steelers. We looked at acute hamstring injuries. We had MRIs that were all looked at by the same musculoskeletal radiologist, and we had what we've come up with, our own Steeler grading system. It's in Sports Health. It's in the upper right-hand corner of your screen there. And this autologous conditioned plasma injections were given to MRI grade 2 only strains. It was given the first day or second day after practice or after the injury. And we kept track of the days lost, the practices lost, and the games missed. And we compared those that got ACP to those that did not get ACP. There was 108 players in the study, 69 grade 2 hamstring strains, 30 athletes got ACP, 39 did not get ACP. So what we found is those that got ACP, their age was 28. You guys may not know these positions, but linebackers, wide receivers, cornerbacks, they're people that run a lot. The long head of the bicep was the most common muscle involved. One athlete had a bilateral, believe it or not, hamstring that was injected. We've only had one reoccurrence with those people that got ACP. Now that's extremely low, because what you see without and a hamstring that is not rehabbed appropriately, you're going to get a recurrence. And if you get a recurrence, it's going to be about twice as long as the original injury. The no ACP, the guys were a little bit younger, almost 26. The same muscle was involved. 3 of them were bilateral. We had 1 recurrence. What we found when we looked at missed time was that the days missed, the practices missed, and the games missed were much shorter. Now the games missed are highlighted there. If you miss 1 game, you're missing at least 7 days. If you're missing 2 games, you're missing at least 14 days. So the conclusion was that ACP for acute injuries, hamstring injuries in the NFL allows for a faster return to play than those that were not using some type of ortho-biologics. Dr. Bradley claims that he has 1 recurrence that was his fault. We did try to get an athlete back quickly for a end of season playoff game, and he re-injured it after getting ACP. But like I said earlier, time loss, whether it's in the Gaelic Athletic Association, whether it's in the Premier League, or whether it's in the NFL, is a big deal. You lose a player, money's involved in some of the professional sports. So if we can decrease the amount of time they miss and reduce the risk of re-injury, it's a good thing to do. This has just been published in the American Journal of Sports Medicine just recently in 2020. There's also an article from 2005. Now, this last thing is, there's a physician listening. We avoid white blood cells in our ACP because we know that's bad for the hamstring, but much better for that. PPP stands for platelet poor plasma, is better for tendinopathy. So the protocol that's used is, we talked about everybody getting an MRI, 24 to 48 hours for the first injection. That next thing, it simply refers to, that's a clotting agent that was used initially, but is not used anymore. The first, second, and third injection are given about a week apart. Sometimes they don't get a second injection. Sometimes they don't get a third injection if they're doing very well. It's the same routine therapy, and the routine return to play. We talked about the plank test. We talked about the last 15 degrees of knee flexion, and then depending on your sport, what functional tests are necessary. So in our phase 2, if they start this ACP, we only wait about 24 hours. They start back with this rehab, and our goal in the second phase is to regain pain-free strength through a full active range of motion. We want them to have good neuromuscular control of the trunk and pelvis, and we want to avoid the end range. We want to avoid stretching if it's uncomfortable. So here's the rehab. Stationary bike, we might use an elliptical. A HydroWorks pool is an underwater treadmill, and an Alter G is a treadmill that has air, and it unweights the person when they run. So we have an underwater treadmill. We have this Alter G that's on it's land-based treadmill, but it unweights you through air pressure. We work on things like single leg balance with a ball toss. We do supine hamstring curls with a Swiss ball. We do hamstring curls, emphasizing the eccentric phase. We do straight-legged deadlifts, Nordic hamstring exercises, lateral and retro band walking, soft tissue massage, and we use instrumented assisted soft tissue massage. This is a Nordic hamstring. I think you're probably all familiar with it, but this is the best exercise that we know that can prevent hamstring injury or help alleviate the risk of hamstring injury. During the second phase, we also considered something called blood flow restriction. Blood flow restriction is something that's relatively new in the United States. It's happened around 2010. There was a gentleman that by the name of Johnny Owens that was a physiotherapist at one of our Army hospitals. It's called the Center for Intrepid in Texas. And he was trying to save the limbs of people that were at war in Iraq, Iran, and Afghanistan that had badly injured limbs from blasts, from bomb blasts. And he found that using this blood flow restriction that was developed from a gentleman by the name of Dr. Sato, and he did Kaiatsu training in Japan in the 60s. He found that it worked, that with less weight, we got good hypertrophy and muscle endurance. And we could use it not only in those Army athletes, but also in the elderly. And we use it today after surgery. We use it after hamstring strains, that there's improved muscle activation and a hormone response. It was introduced to the NFL by the team in Texas, who had an athlete by the name of Giovanni Clowney, who had a terrible knee. He had tricompartmental degenerative disease. He had a very difficult time doing his weight training, and their team physician consulted Johnny Owens in Texas and brought that to the NFL, and it has really exploded in our sports medicine world. So the phase 3, symptom-free, symmetric strength, good muscular endurance, good neuromuscular control. The rehab, we get people running. A strider is something that we do at 70 to 80% of perceived maximal effort. We do a goal of 12 to 15 reps with a 30 to 45 second rest, and that's about 50 yards across the field. Cutting, angular movements, plyometrics, acceleration activities, sports-specific skills, they're all part. We use a catapult device. We use that during practice. We have those numbers so we can use those numbers when somebody returns to competition. We think that in injury risk management, we use it for comparisons, how fast they're running, how far they're running, how many explosive movements. And it's not just the catapult system. There's something called a zebra system as well, or sports science systems and Conduct, Coach Me Plus, Impelia, Polar. We use those analytics, and I'm in its infancy of understanding these analytics, but we think it's of a value for us to have these analytics to get them to return. It's a team approach here. We have athletic trainers, we have a physical therapist, we have physicians, we have our strength and conditioning people, there's chiropractic, there's massage therapy. So there's many people that assist in doing this. It's not a one-man show. This is a group of, this was us, this was at a game this year. You see how many people are in the stands, but this is a preseason game, and these are the folks that assisted us in taking care of the athletes. Routinely, there's 5 athletic trainers. Our chiropractor and one of our physicians is in this picture, but these are people that assisted us during camp. You know, my way is, our way of rehab is not the only way. I attended a conference where somebody talked about getting their athletes, as Canadian sports scientists that have people try to sprint as soon as they can. My fear is re-injury. This is his philosophy. There's many ways to bake a cake. Our way may not be the best. But I think the keys to our success are identifying those people that have had a prior injury, establishing an intervention program, and if there's no history, we try to do a lot of Nordic hamstring stuff. If they had a previous injury, it's eccentrics in a lengthened state. We do want to, at that time, is try to have no deficit at the end range of motion. For rehab, keys to success: start early. It should be pain-free. Attempt to use objective measures. Don't return them too early. And after they're done, continue an eccentric strength program. These are things, there's a musculoskeletal committee in the NFL. These are things that they send out to our players. And they send out these type of little blurbs to make them realize that they have a responsibility for protecting themselves. This is another one where it's specifically focuses in on hamstring strains, and as it says, the #1 predictor of a future hamstring is a previous strain. We think that Nordic hamstring exercises are the only thing that is has any clinical significance or any proven value, scientific proven value to help prevent hamstring injuries. This is their slide on hamstring, or their little video on hamstrings. These are the resources that I've used. I'll be glad to share them with anyone. And the last thing I want to say is that those of us that are a physiotherapist or an athletic therapist or a sports scientist or even a physician, the last thing you want to do is draw attention to yourself. Well, I'm sorry you didn't get to see that video I had at the Super Bowl, because this is when we scored our last touchdown, and there was only a few seconds in the game, and I think we had it sealed up. And our head coach is that gentleman that's staring at the guy pumping his fist. And I did draw attention to myself, but I was pretty excited at that Super Bowl. So thanks for listening to this webinar. I'm here to answer any questions. I hope it was of value. I hope I didn't embarrass the NFL, UPMC, or any American. So if I can answer any questions, I'm here for you.
Thanks very much, John. Very, very good presentation, and we've quite a number of questions here for you. I'm just going to throw you up on the screen there, if that's okay.
Sure.
Okay. So I'm just sending you there. So, John, just a number of questions we have there. What advice would you give a player straight away after a muscle injury?
To take some time and let the thing heal. Don't push motion, you guys. When you strain an adductor, a groin, or you have a hamstring or a quad, I think that if you rush into trying to put tension on a healing muscle, that it's going to only aggravate and inflame that muscle, and it's going to last a little bit longer. So what we talk about all the time in our training room is to progress in a pain-free manner. If it hurts, or it hurts a lot, you're only going to exponentially increase the amount of time that's lost.
So just sensible progression.
Yes, I do think that.
Perfect. Next question there is, you mentioned about GPS and the catapult system that you use. What are the main metrics you look for in the GPS in terms of injury prevention?
Well, as I said, for injury prevention, I can be honest with you. I would lean on the sports scientists that we have, our strength and conditioning folks. We look at a decrease in 15% of speed or 15% loss in angular movements. But my goal with this is I look at angular movements, I look at high speed, I look at distance, I look at velocity. They're the important things for me as we rehab an athlete. And that's controlled by our strength and conditioning staff.
Okay, very good. And how do you manage older players versus younger players in terms of overall training load? Do you have a philosophy on that?
Well, remember, the players that I get are usually 21, 22 when they come to us the first time. If someone goes over 30, they're very old. We do manage them, and our older players, if I know someone has an arthritic knee or has some type of spine pathology, they may not practice every day. And that's a communication between the strength and conditioning folks. That's a communication with our room. That's a communication with the head coach. And the head coach is the one that has to have the buy-in. If the head coach doesn't have the buy-in and wants to push those athletes, at least in the National Football League, they have the final say.
Okay, perfect. And another question here. If you had to pick one movement screen, what would it be?
Well, we've talked about movement screens in the NFL. We do those movement screens at the NFL Combine, and we've looked at their relationship to injuries down the road. And the correlation has not been very strong, at least in our hands. Maybe there's a better way to do movement screens. Maybe there's something that we're missing, but the correlation between a risk for injury and movement screen, at least in our hands with our 32 teams, and looking at a movement screen and providing a good grade and looking at the injuries at a later time, we've not been very successful with that, to be blatantly honest.
Perfect. Thanks very much. And in terms of for players outside running and gym programs, what advice would you give these players to what should they be doing in terms of running and the gym to reduce injury risk?
Well, the big thing that we concentrate on initially is endurance. We don't worry about speed. We work on building up an aerobic fitness base, and then we work on anaerobic after that. But we talk about strength, we talk about conditioning, and that's a portion of it. There's also a recovery period. We use hot and cold plunges, we use foam rollers, we use chiropractic, we do have stretching afterwards. And I think that plays a role in recovery. Nutrition plays a role in recovery. I think the amount of rest that you get at night is certainly very important in recovery. And I think if any one of these is out of balance, that you put that athlete at risk.
Perfect. There's actually a couple of questions here on recovery, so it probably leads me into it there. You've mentioned a few of them there. What are the best methods of recovery for your players post hard training and hard games? You mentioned sleep, nutrition. What do you hammer home with your players there for them to do post training?
Well, the day after a game, we have them in and they do submaximal exercise. They may do some light running. They may work on a piece of equipment like a stationary bike or an elliptical unit. There is some light stretching. They will go in the weight room and lift. And there's certain modalities that we use, and I don't know what type of effect they have. We have guys that'll jump in our hot and our cold plunge. We have guys that'll jump in a steam room. But I think the most important thing is some light exercise and stretching, along with nutrition, along with getting adequate rest. Some people like massage. We have massage therapists that assist us as well. So I think as our players become more veteran, they know what works for them, and we try to provide whatever services that they feel are necessary to get them ready for the next game. We will generally provide that. We're fortunate. We have good resources. There's a lot of money in this league, and they're willing to spend it so that we can have our athletes be ready for the next week.
Okay, so that's very much individualized, which is interesting. And in terms of recovery time between, we'll say, match day and the next training day, that was a question there. So you mentioned that they probably would do something most days, but would they have down days in between as well?
Tuesday is our down day. If we play on Sunday, one Sunday, and we play the next Sunday, Monday and Tuesday are recovery days. Wednesday is a hard practice. Thursday is a hard practice. Friday is a light practice. Saturday is a very light practice. And then we play on Sunday.
Okay, so you have a 48-hour window there, which is recovery based before you do any hard training again.
And in my case, that allows us to evaluate those athletes in whatever studies to determine. We have to have a good idea by that 48-hour mark who's going to be available for the week.
And then in terms of cryotherapy, what methods of cryotherapy do you use?
We have a ice bath that's maybe 36, 40 degrees, and then we have a cold plunge, which is about 38 degrees, which is a small swimming pool. It can fit maybe 12 athletes. A hot tub is at 104 degrees. That's right next to it.
So I've a question in here, slightly different. It's obviously a Steelers fan. How did the Steelers go so long without COVID last year? Other opponents weren't so lucky. Did you train remotely, or had you?
Well, we did try to have our own bubble,
Yeah.
and I and the players got tested every day from July 28th till the end of our season. So if we did have the start of an outbreak, we were on it pretty quick. We did do the things that they're probably emphasizing in Ireland: social distancing, wear a mask. All our meetings were virtual. We didn't have team meetings together. When we traveled, there was a certain protocol that we followed. We didn't travel with as many people. At our hotels, we didn't eat in a room together. We picked a boxed lunch or dinner up and went back to the room. It was very unique.
Yeah, and I suppose
we had our cases too. We had now this is back May of 2020 till today. I think 32 of our athletes have had COVID. So there's been more than you think. Yeah,
but you were obviously on top of it fairly quickly and following them protocols as all our club players are returning back to training. It's I suppose important that we all follow the guidelines that are set out by the government and the GAA. And just one last question then.
Well, I'm going to interject there. I'm going to interject. As soon as you guys can get the vaccine, we think it's very, very safe. I hope that everyone's in line to get that vaccine, because the sooner we reach herd immunity, the sooner we have people in the stands for camogie and hurling and NFL, all of it. That's what we want.
Yeah, no, we're slightly slower behind you now with the rollout, but we're getting there. So just one last question then. What pre-training routine do you encourage players to complete before they do their warm-up?
Well, again, that's very individualized. Some players like to be stretched out. Some people like to use a foam roller. Some people sit in the warm water, a hot tub, and get out and then do their stretching. Some athletes will go out pre-game and walk around the field or do some activities on the field that are submaximal to kind of warm their body up before we actually go out and do our team warm up. So it's an individualized thing. We don't give anything to our athletes and say there's not a protocol. This is what you have to do before team stretch. It's really up to the player. When we get those players, they're professionals. They've been through colleges. They've been through their high schools, and many of them have a routine that they developed to get to our level. Does that make sense?
Yeah, no, that makes sense. Look, John, we'll leave it at that. There's loads of questions there, and thanks very much for your in-depth knowledge in the presentation and your honesty with all the answers that you're after giving there. And thanks very much for taking up your time and the preparation it took over the last number of weeks. So we thank you sincerely. I'm now going to pass over to Des Ryan, who's going to give us an update on the programs.
Thanks, Cathal, and more importantly, thanks, John. And you're a humble man, so you probably won't want me saying this, but after meeting you for the first time, it was clear to me that you were one of the most experienced practitioners I've ever met, and I've met a lot of practitioners, and alongside that, the nicest thing, a gentleman. So it's fantastic that what the late Dan Rooney instigated, the connection between the Steelers and Ireland, has continued. And some of the people you mentioned at the start asked me to pass on their good wishes to you and a hello to you, like Liam Hennessy, Gary and Barry O'Driscoll. So they were delighted to hear that the relationship between the Steelers and Ireland has continued. So we were delighted to have you here representing UMPC and helping us out here at the Be Ready to Play program. So thank you. We're delighted to have you. And just for the people listening in, a short update that exciting times here with the adult team returning to training. The young players, the underage players are back training, and that's brought a lot of joy to people, both parents, guardians, coaches, children, youth, adolescents. It's fantastic to see. So there's some good information for people on the GAALearning website. Safety first and foremost. So the COVID-19 club education is there, and some very practical documents to help the clubs with this return. And with the adults returning on the 10th of May, valuable information there. And concurrently with this, with the coaching webinars, with the sports science webinars, the athletic development program is still going. That needs to be done right through the season to maximise your participation, your enjoyment, your performance. And we're taking into consideration the return of the adults to training on the 10th of May. Also, you'll find there return to training advice, a handout, a simple, easy to use handout, and a webinar with myself and Mick Dempsey going through the information there. And I think that's vital for coaches, players, anybody involved returning to training. And it doesn't take too long, just a 20-minute webinar and a 2-page handout. So thanks for attending, thanks for listening and taking part in the Be Ready to Play programme. That's the update from me, so back to Cathal.
Thanks, Des. So before we finish up, I just want to give an update as to where we're going with the webinar. So next Tuesday night at 7 p.m, we're lucky to, as part of the sports science series, Dublin footballer Kevin McMenamin, who's a sports psychologist consultant, and Dr. Kieran Kearney, high performance psychologist and lecturer, will give a talk titled "Ahead for Sport: Applying Sports Psychology in Gaelic Games." And 2 weeks after that, we will have Meath senior football coach and Leinster GAA tutor Colm Nally with Martin Fogarty, who was the National Hurling Development Manager and former All-Ireland winning coach and selector with Kilkenny, doing a webinar, a coaching webinar on developing the coaching eye and how to progress a skill. So we have a great lineup for these 2 Tuesday nights, and the following 3 months then we'll be launching a summer series of webinars from top speakers as well. So I'd just like to thank everybody this evening, and I hope you enjoyed, and thanks to Des and John for their contributions. We hope you have a good